All right, class. In today's lecture, we're going to finish up chapter 13. And one of the first things we're going to talk about in our third lecture, or our third part of chapter 13, is how the brain actually protects itself. We have four major ways of protection, with the first one being the obvious, the skull. So we utilize bone tissue really to provide this hard barrier around the brain. We also have small little membranes, which we know as meninges. We have a watery cushion, which is what our cerebrospinal fluid is, or our CSF. And then lastly, we have our blood-brain barrier, which acts as more our chemical barrier to the brain. So we'll skip over the bone, as that's more skeletal system. But one of the things we start to look at are the meninges. And when we look at meninges, there are three layers. We have the dura mater, the arachnoid mater, and the pia mater. Our first layer is the dura mater. It's the strongest of the Menics layers, and it's also the outermost layer. It's formed by two layers of fibrous connective tissue that surrounds the brain, and they separate at certain points to form these dural sinuses. They also form septa, which help to limit the movement of the brain as they attach in different locations. One of those locations that attaches is going to be at the crista galli. And this particular septa is going to be called the falx cerebri. And it's going to be found within the longitudinal fissure. Our second part of dural septa are going to be the falx cerebelli. And it's going to be located along the vermis of the cerebellum. And our last one is the tentorium cerebelli. And these are the horizontal dura, and they actually fold over the cerebellum and are within the transverse fissure of the brain. So if we look at these, here's our mid-sagittal section of the brain and the skull. You'll notice that going right down that longitudinal fissure here is our falx cerebri. You'll notice at the very bottom side that goes into the cerebellum through that vermis is the falx cerebelli. And then the one you can't see, so we kind of make the jump over here, would actually be the tentorium cerebelli. And that's going to go right along the side here in that transverse fissure. You also notice on this graphic that we have the sagittal sinuses that basically run up and down and also side to side on that brain. And we'll talk more about those in a second. Our next layer is the arachnoid mater. And the arachnoid mater is just deep to the dura mater. It's the middle layer with web-like extensions, and it's separated from the dura by the subdural space. When we look at the subarachnoid space, it contains the CSF and blood vessels. So just below the dura, we have a subdural space, and just below the arachnoid mater, we have a subarachnoid space. We're also going to have these small little protrusions of arachnoid mater, and these are called arachnoid villi. And they protrude into the superior sagittal sinus, and they permit cerebrospinal fluid reabsorption. Our third meningeal layer is the pia mater, and it's the deepest of the layers and tightly clings to the brain. And it's a very delicate layer of vascularized connective tissue. So we can take a look at this cross section. You'll notice up here in purple where it is. So we're just looking right across the layer of brain tissue and of the skull. And you'll notice that we have the skin of the scalp. Just underneath that, we have the periosteum of our bone. And then we have the skull bone itself. Just deep to that skull bone then is going to be the dura mater. And so we have the epidural space above that. And then we have our two layers, the periosteal layer and the meningeal layer. And you'll notice right here where my red pointer is that these are the combination of the two layers, but they do happen to split off. And as they split, you'll notice that we have this dural sinus here in blue, but within that dural sinus then is our arachnoid villus. And that arachnoid villus is this extension of the arachnoid as it protrudes into those sinuses. And this allows the reabsorption of our CSF fluid into those sinuses. Just below that, or just below the arachnoids, the arachnoid mater, is going to be the subarachnoid space where we have our CSF and we have our blood vessels. And then the layer that tightly clings to the brain tissue itself is then our pia mater. So one of the things that we talked about is CSF, and that's cerebrospinal fluid. Well, in order to understand CSF, we have to understand what it's made of. It's mostly made of water, but it does have a little bit of protein, and it does have a lot of ion concentrations. But a lot of these are less than what we find in plasma. It also has a constant volume. And so while it's constantly being reabsorbed, it's also constantly being made. And so in order to look at how it's made, then we have to look at a structure called the choroid plexus. And the choroid plexus produces CSF at a very constant rate, and it hangs from the roof of each of our ventricles. We're going to find that there are a bunch of clusters of capillaries that are really enclosed by the pia mater, and also a layer of ependymal cells. And then the ependymal cells use ion pumps to control the composition of the CSF, and it helps to cleanse the CSF by removing waste. And so it keeps it relatively clean by constantly going through that cleansing process. So here's a look at the choroid plexus. You can see that we have a capillary, and that capillary is going to be surrounded by these ependymal cells, as well as this layer of the pia mater. In here is where we notice, or where we will find the CSF. And the CSF forms from the blood plasma and the ependymal cells and enters the ventricle. So as we go through the production of CSF, you'll notice that in the ventricles we have the choroid plexus hanging from the roofs. But you can kind of see and follow along the pathway of CSF flow as it moves in through the sinuses and as it's also created. You'll notice in one here we're created, it moves down in through the ventricles, going through the cerebral aqueduct as it gets moved into different areas and into the sinuses, around the central canal, going down the spinal cord. It can also wrap back up, come all the way back around the brain, and then again it's able to be filtered back into those sinuses through our arachnoid villus. Here's a little closer look of the arachnoid of one arachnoid villus as it enters into the dural sinus. And you'll notice here that this is the way that CSF is able to be absorbed back into our sinus of the dura. Our next way that we protect our brain is through the blood-brain barrier. And the blood-brain barrier is basically our chemical barrier, and it helps to maintain a stable environment for our brain tissue. It separates the neurons from a lot of blood-borne substances. And the blood-brain barrier then is very selective on what types of things are able to get into brain tissue. Its composition is endothelium of the capillary walls. It also has basal lamina, and then we also utilize the feet of our astrocytes. And the feet of the astrocytes actually provide the signal to the endothelium for the formation of very tight junctions around those capillaries. So as we take a look at the blood-brain barrier, we take a look at one example here. Here's our capillary. And here you'll see the astrocyte. So we have this extension, or these feet, that basically form all these tight junctions and essentially forming a relatively impermeable barrier, again with some exceptions, in which only certain things are able to pass through and get into our brain. So as we look at a few conditions of the brain, one of the things we have to look at are some of the common ones. And the common injuries really are more traumatic type of injuries. One of the obvious ones that everybody seems to be familiar with is a concussion. And a concussion is typically a blow to the head that has some sort of temporary alteration in function. There are multiple grades or multiple levels of a concussion. The most common is a grade 1, which basically is just a blow to the head. You may have a little bit of a headache, um, maybe some very temporary alteration in where you're at. But typically, or not typically, there is no loss of consciousness with a grade 1 concussion. And then we obviously get into grade 2 and grade 3, which are more severe. A contusion is essentially like what we typically see with muscle tissue. A contusion in muscle tissue is a bruise. The difference is that when we get to a contusion in the nervous system, or particularly in the brain, it has a more permanent issue or causes permanent damage. Whereas a bruise in your muscle, you know that over a few days that'll eventually go away. Again, a contusion in the brain causes permanent damage. Our next one is a subdural hematoma. And a subdural hematoma is essentially a bleed that occurs within that subdural space. The significance of this is that if it gets big enough, it can actually continue to grow and grow as far as the bleed goes. And as the blood starts to take up space, it's going to force the brain to expand outward. Well, when you look at the skull, there's really only one way for it to go, and that's to go towards the foramen magnum. And so if a subdural hematoma gets big enough, it can actually force the brain stem towards the foramen magnum, try to force it through, and actually result in death. This is typically from ruptured veins, from some sort of fast rotational head type of movement. Our fourth type is some sort of cerebral edema. As many of you may know, edema is basically swelling. So in this case, we're looking at swelling of the cerebral cortex, or swelling of the cerebrum, the brain. So this is a swelling of the brain associated with some sort of traumatic head injury. We also have a cerebrovascular accident, or CVA. Now, this is not a traumatic type of injury. This is what we typically think of when we talk about a stroke. It basically is a reduction in the blood supply to part of the brain. And very often, it's because there is some sort of blocked arterial blood vessel or a hemorrhage. Oftentimes, it's because of a blood clot that just gets stuck in one of the arteries. With a CVA, it can typically cause brain tissue death if it's prolonged for several minutes, because the brain and brain tissue is one of those organs and one of the type of tissue that needs oxygen on a very constant basis. If you go without oxygen for just literally a few seconds, you actually run the risk of passing out. It's what happens if your carotids get cut off, or if you ever see a chokehold that gets too tight. It can actually compress the carotid vessels and prohibit blood from actually getting to the brain. Symptoms of a CVA or a stroke typically are going to involve blurred vision, weakness, headaches, dizziness, and walking difficulty. And one of the acronyms that we'll use with a stroke is FAST. And so when we think of FAST, we should be looking at the face, the arm, the speech, and time. So we look at the face to see if there's any drooping of the muscle tissue. We look at the arms to see if there's any weakness of the arms. Are you speaking clearly, or do you have some sort of slurred speech? And then lastly, if you have any of those that indicate some sort of stroke, it means you have to move fast. So you have a very limited amount of time. And oftentimes with a CVA or with a stroke, you're going to see the effects be on the opposite side of the body. So again, if you have a stroke on the right side of the brain, you typically are going to see the effects occur on the left side of the body. Now, we can also have a brief type of CVA which is called a TIA, or a transient ischemic attack. And these are reversible. Again, they're very short, very brief. There's some sort of blockage that you start to maybe see the symptoms of a stroke, but they immediately clear up because, again, it is a brief episode. However, those that have experienced a TIA are at a greater risk of having a stroke down the road. Now, we also have some degenerative brain disorders. And one of the most common ones is Alzheimer's. Now, Alzheimer's disease is a progressive degenerative disease of the brain that typically results in dementia. And again, it is, as it progresses, it does become a fatal disease. Parkinson's is the degeneration of the dopamine-releasing neurons of the substantia nigra. And we have talked about Parkinson's very briefly earlier when we were talking about nuclei of the brainstem. Again, one of the treatments or one of the medications that we'll use for Parkinson's is dopamine. And that obviously kind of adds to the dopamine that is not being released by the substantia nigra. And our third degenerative brain disorder that we'll talk about is called Huntington's disease. And it's a fatal hereditary disorder that's caused by an accumulation of the Huntington protein. And this also leads to the degeneration of brain tissue, but specifically it degenerates the basal nuclei and the cerebral cortex. So now we'll get into our cranial nerves. Now, with cranial nerves, understand that the nuclei of the majority of our cranial nerves are going to be found within our brain tissue, whether it's in the brain or whether they're going to be associated more with the brain stem. But understand that the cranial nerves themselves are actually a part of the PNS. When we look at cranial nerves, they're all paired, so you're going to have one on each side. And there are 12 pairs of these cranial nerves. Again, they are part of the PNS, but they do originate from the brain or the brain stem. Our cranial nerves are numbered with Roman numerals according to their position, numbering 1 to 12. And they begin with the most anterior located nerve. Now, as we name them, the name of the nerve is often related to the function that it serves. So I do have a few acronyms here that you can utilize. Some of these are going to indicate the name of the nerve, and then the rest or the other will actually identify whether it's a motor nerve, a sensory nerve, or both. So you'll notice up here there's a few bold letters. On occasion, our trusty truck acts funny, very good vehicle anyhow. These are all the first letters of the 12 cranial nerves. Now you'll notice that right here for the 11th nerve, it has an A in this one. In this acronym, the 11th nerve is an S. What that indicates is that the actual name of the nerve is either called the spinal accessory nerve, which would be the S, or in some cases, it's actually called the accessory nerve. And so therefore you see the A. And then again down here indicates whether we have a motor nerve, a sensory nerve, or both. So as we look at the brain, you'll notice you can see where all these cranial nerves are coming in at. While you may not be able to see the nuclei, you can actually see the nerves themselves. And we're not going to sit here and go through them, but you can at least take a look to see where they are located. So the next few slides, we're actually going to go through all of our cranial nerves. Now, for our purposes or for testing purposes and quizzes, there are a few things that you want to be able to identify. You want to know what nerve number it is. You want to know what the name of the nerve is. You want to know whether it's a sensory nerve, a motor nerve, or it has fibers for both motor and sensory. And then you also want to know what the function is. So those are some of the key components to understanding each of these nerves and what you should be able to take away from each of the nerves. So our first cranial nerve is cranial nerve 1, and it's called the olfactory nerve. and it's going to serve as a sensory nerve for olfaction or for the sense of smell. And you'll see it here. Here we have the olfactory bulb, the olfactory tract as it leads into the olfactory nerve. But you'll also notice that we have these fiber extensions that protrude through the cribriform plate of the ethmoid bone. This allows then chemicals to come through the nasal passage and stimulate these nerve endings within that nasal passage. Cranial nerve 2 is called the optic nerve. It is also a sensory nerve, and it serves as a sensory nerve for vision. You'll notice here we have the cranial nerve for the left eye, the cranial nerve for the right eye. You'll notice that certain parts of them cross over, and once they cross over, then now we have the optic tracts. And from back here, you'll notice that we see all these fibers that go towards the back of the brain into the occipital region or the occipital lobe of the brain as it gets into our primary visual cortex. Our third cranial nerve is called the ocular motor nerve. Now, cranial nerve 3 is a motor nerve, and it's going to control the muscles that help to move the eye, lift the eyelid, change the pupil diameter, and also change the lens shape. Now, one of the things that isn't listed here that we really should know is that with cranial nerve 3, this has parasympathetic fibers. And we'll talk a little bit more about that when we get into the autonomic nervous system, I believe in chapter 15. Now, there's going to be 4 cranial nerves that are going to exhibit parasympathetic fibers, and I will identify which 4 those are when we hit them. But the first one that's going to have parasympathetic fibers is going to be cranial nerve 3. Cranial nerve 4 is called the trochlear nerve. The trochlear nerve is also a motor nerve, and it controls the superior oblique eye muscle. So one of the ways that you're going to be you'll be able to remember this, because we'll touch on this when we get into cranial nerve 6 as well, is you'll want to remember this phrase, SO4 LR6. So SO4 indicates the 4th cranial nerve, and it's associated with the superior oblique muscle. LR6 indicates the 6th cranial nerve, and it's associated with the lateral rectus muscle. And we'll talk about that again when we get into the 6th cranial nerve. So cranial nerve 5 is called the trigeminal nerve. The trigeminal nerve is a mixed nerve, and it receives somatic sensation from the face. So it's got sensory components. It's the nerve that detects sensation when the face is touched. It also controls the muscles involved in chewing, or what we call mastication. So again, this is a mixed nerve, which means it's got both sensory and motor fibers to it. Cranial nerve 6 then is the abducens nerve, and it's a motor nerve that controls the lateral rectus muscle that abducts the eye. So basically, it's on the outside of the eyeball. When it contracts, it moves your eyeballs outward so that you can see what's going on further out than what your body is. Cranial nerve 7 is called the facial nerve. Now, the facial nerve is a mixed nerve, and it's going to control a lot of the muscles of facial expression. But it also does conduct taste sensations from the tongue. So the facial nerve helps to control facial movement. Sensory-wise, it involves taste. Now, this is also another nerve that contains parasympathetic fibers. So we have cranial nerve 3, cranial nerve 7. These 2 so far contain parasympathetic fibers. Cranial nerve 8 is a sensory nerve, and it's involved in hearing and equilibrium. So it's the nerve that basically picks up sound waves and allows your body to interpret sound. Cranial nerve 9 is the glossopharyngeal nerve. Now, it's a mixed nerve that receives taste and touch from the tongue and has motor control of a pharynx muscle. So the glosso typically refers to the tongue, pharyngeal refers to the pharynx. And so we're looking here at both the tongue, so it involves taste and touch, and then we also have motor control of the pharynx region. Cranial nerve 9 is our third nerve that contains parasympathetic fibers. Our 10th cranial nerve is called the vagus nerve. Now, the vagus nerve is a mixed nerve that controls the muscles in the pharynx and the larynx. It conducts sensation from many of our viscera and is also a major source of parasympathetic output. So again, this is our fourth nerve then that involves the parasympathetic system. But again, this is also one that crosses or leaves the head and neck region. So it actually will go down into the abdomen, down into the thoracic cavity and the abdominal pelvic cavity, and innervates a lot of the tissue in those regions. Cranial nerve 11 is called the accessory nerve, or sometimes you'll see it called the spinal accessory nerve. Now, it can be called the spinal accessory nerve because the fibers of the spinal accessory nerve will actually come off of the spinal cord at the upper cervical levels. As those rootlets will come off, they actually go up and enter the skull before they come back and exit the skull. It's going to innervate muscles of the neck and the pharynx, particularly the sternocleidomastoid and the trapezius muscle. It is simply a motor nerve, so it only has motor control. But again, with the spinal accessory nerve, it's going to control two muscles, the sternocleidomastoid and the trapezius. And I went ahead and circled them down here for you. Our final cranial nerve is the hypoglossal nerve. And it's a motor nerve that's going to control the tongue muscles. Again, you see that terminology in here, the glossal component, which references the tongue. So again, this is cranial nerve 12. And now that we've come to the end of chapter 13, I'll just make, since I didn't do anything earlier, I'll just make hypoglossal as our code word for the day. So pretty easy the last couple lectures. Both of them have fallen at the end of the lecture. So again, today's code word is going to be hypoglossal. Otherwise, that'll be it for today's lecture. And this is the end of chapter 13. We'll pick up with chapter 14 as we get into next week.